Hello, I am Mohammed Dlewati, and I'm pleased to present a challenging case of respiratory failure in a patient with stage 4 diffuse large B-cell lymphoma. Lymphomas can arise in lymphatic tissue of the body, in addition to the less common extranodal lymphomas. Diffuse large B-cell lymphoma, specifically the ABC phenotype double expressor, carries a poor prognosis. Lymphadenopathy in the nodes of the upper respiratory tract, including those in the nasopharynx, larynx, and trachea, as well as enlargement in the lymphoid tissue of Waldeyer's ring, can lead to upper airway obstruction. A 70-year-old female with a recent diagnosis of stage 4 diffuse large B-cell lymphoma presented to the emergency department with acute onset encephalopathy and respiratory failure. Regarding her recent diagnosis of diffuse large B-cell lymphoma, a biopsy of a cervical supraclavicular lymph node had revealed large B-cell lymphoma with high proliferation index, 80 to 90% by Ki67 immunostain, and an activated B-cell phenotype, also known as ABC type, and double expressor for MYC and BCL2. Arterial blood gas on arrival on a non-rebreather mask revealed an acute on chronic respiratory acidosis with marked hypercapnia, and that's with a pH of 7.16 and a PCO2 of 113, and an increased AA gradient with a PO2 of 164 on 100% FiO2. The bicarb was also elevated to 40.3. She was emergently intubated after failure to improve with BiPAP ventilation. CT scans of the neck and chest showed marked bulky lymphadenopathy in the nodes of the floor of the mouth, nasopharynx, cervical, and supraclavicular lymph node chains. CT pulmonary angiography revealed no evidence of pulmonary emboli, clear lung fields, and present mediastinal lymphadenopathy. She was found to have pulmonary hypertension with an RVSP of 63 millimeters of mercury as estimated by echocardiography. We can see under imaging the images of the upper airway that depict the lymphadenopathy and airway obstruction. These are in cross-section in images 1 and 2, in sagittal view in 3, and coronal in 4. Enlarged submental lymph nodes are visualized in 1 and 3, indicated with teal arrows, enlarged submandibular nodes in 2 and 3 with red arrows, and in numerous cervical and supraclavicular enlarged lymph nodes in 4 with green arrows. Shortly after intubation and initiating mechanical ventilation, the patient returned to baseline neurologic status. She was treated with 40 milligrams of intravenous dexamethasone daily for 4 days and maintained on 4 milligrams oral daily thereafter. Requiring minimal ventilator support, she was successfully extubated on day 3 of admission. The patient subsequently had repeated admissions with a similar presentation and was treated with either non-invasive positive airway pressure therapy or intubation with mechanical ventilation and more corticosteroid therapy. During admissions, she was too ill for chemotherapy, and after receiving 1 day of R-CHOP therapy, she developed tumor lysis syndrome and received thereafter no further chemotherapy. Tracheostomy was considered, but not pursued, especially in the setting of refractory severe thrombocytopenia, despite treatment with HLA-matched platelets. After goals of treatment, conversations with family and the patient and her family, they elected to transition to hospice care. The key points and discussion from this case: diffuse large B-cell lymphoma ABC phenotype double expressor carries a distinctly poor prognosis. Early consideration for airway management in cases of lymphoma with upper respiratory tract involvement is warranted prior to complications arising from therapy or disease progression. Early tracheostomy can be considered to avoid acute and rapidly progressive respiratory failure due to worsening disease. Tracheostomy may be technically challenging due to anatomical distortions by pathology, including tracheal deviation, increasing risk of tracheal injury. And in lymphoma with upper respiratory tract involvement, additional screening and monitoring for new onset or progression of chronic respiratory failure syndromes, such as obstructive sleep apnea or pulmonary hypertension, are warranted. Thank you for your time and attention.